So our first case will be of cystitis in pregnancy. If a patient comes first, you have to do is a female, then she come in our office, then we have to do physical examination of this patient. We will order beta HCG qualitative serum or urine to confirm the pregnancy and urine analysis. And after that, what we have to do when the result will came of the urine analysis, then we have to advance the test and see the result. If it's positive for cystitis, then we have to order the medications for that. It will be amoxicillin, and we have to order it because in pregnancy we have to do a urine culture to check if the disease resolved or not, because cystitis can lead to many complications in pregnancy. Then we can give prenatal vitamins and counseling for pregnancy. An appointment we will change to 2 weeks. We'll see if the patient approves or not. Then and when the patient come back to the office, and then you order urine culture to see if the like this patient is resolved or not. So what giving medication we can give in pregnancy? We can give cephaloxamine or amoxicillin 7 days course, or we can give single dose of fosfethamine or nitrofurantoin, but not in second and third trimester. We can give only now in first trimester. Avoid trimethoprim, fluoroquinolone. Trimethoprim is folic acid antagonist, and fluoroquinolone is cartilage damage. But if it's for a uncomplicated cystitis in a normal healthy non-pregnant, then we can give both these medication 3 days course for trimethoprim, 3 days course of fluoroquinolone. So the baseline is that these are medication is given only for 3 days, but for amoxicillin or cephaloxamine, you have to give it for 7 days. And if it's a complicated cystitis, like if it's a male, diabetic, and has anatomic abnormality, if a patient has indwelling catheter, you have to see all these things. Male, diabetic, indwelling catheter, symptoms greater than 7 days, recurrent UTIs, and greater than 65 years of age, then we can go. Then we have to give 7 days for trimethoprim sulfate. So here we have ended the case 1, cystitis. Case 1, cystitis, pregnancy. Next question is if a woman comes with amenorrhea, so how do we diagnose pregnancy? What are the tests we have to do in pregnant? So case 2 is about pregnancy. We'll see what you have to do. Same test we have to do. Beta HCG, urine, qualitative, quantitative. And if she's coming with abdominal pain, then we have to do. And we see if the patient come with, then we have to do, when the urine analysis is positive, then we will do ultrasound. And with that, we also have to do prenatal lab tests like blood type, RH, atypical antibodies, pap smear, urine analysis, because pregnant women you have to rubella infection, rubella antibodies, rapid plasma antigen, hepatitis B antigen, HIV, chlamydia, and the basic test which we do in our patients, CBC, PMP. Then we have to give the patient prenatal vitamins if she is pregnant, iron sulfate, folic acid, and prenatal counseling. We have to follow up in 4 weeks for operation to come, because then we follow up while giving the all these things and tests. Then she will come within 4 weeks, and they will see will ultrasound, which will confirm the pregnancy. She will taking the vitamin. She will have all the test results. So here is the scenario for pregnant women. Next case will be like if a patient come with you with an ectopic pregnancy presentation, what will you gonna do? You have to order the same test we have to do because we have to focus physically because she will be in emergency department with pain. Then you have to order urinary serum beta hCG qualitative. You can order both. It's upon you like urine or serum, whatever. Then you have to advance the clock and see the result if it's positive. Then because we know this pregnancy is positive, then you have she's come in emergency. You transfer her to the ward. Then what you're gonna do is because NPO vital we will take IVSS, IV saline, um, complete bed rest we will do, and then we will order quantitative serum beta hCG because in you have to do in a ectopic pregnancy to see if the level are decreasing or how it will be available in the transient ultrasound. कैसा नजर आएगा? Then we will how will be appear on the transient ultrasound. And the other test because we have maybe we have to do the surgery, then we have to do type and cross matching, blood group, and same. And because whenever we are doing the surgery, we have to do PTPT, VTT, CBC, and BMP, all the patient. We have to do RS factor this. We have to do LFTs because if we have to give methotrexate, and we have to do the presentation mimics the infection, cervical infection, then we have to do cervical gonococcal chlamydia culture, start करेंगे. And then we will see the transmitted ultrasound confirm the diagnosis of ectopic pregnancy. We will see the SCG levels and RH positive. If the RH is positive, then we don't have to give ROCOM. If these are positive, then we will consult OBS and gynae consult, and we will give methotrexate and morphine to the patient. For morphine for the pain, we take use of um, mm, whenever we give patient methotrexate, we have to follow up in 4 days to monitor serum beta hCG level if it's decreasing or not. So what we are gonna do if patient is stable? If patient is stable, we have to look why are we checking vital sign? We have to look for signs of rupture. If the ectopic pregnancy rupture, then it will be like increase of the pain, tiredness, shock, and labor. It can be anything, and we have to check again and again continuous beta system. We perform the transfusion ultrasound, and if the transfusion ultrasound show 1500 levels greater than show the intrauterine pregnancy, then ectopic pregnancy T for normal IUP. If the beta CC level are 1500 more than and doesn't show IUP, ectopic pregnancy is likely but unconfirmed. Repeat testing in 2 days. This is the word we have learned algorithm of U-word. And if beta HCG level is less than 1500 and there is no intrauterine pregnancy or active we have to do the same. Repeat testing in 2 to 3 days. If 1500 level more than transmitter show enough throughout, ectopic pregnancy is confirmed. Proceed with the following management option. Methotrexate for when a stable patient with beta HCG level. These are some indications. For one, we have to do methotrexate. Like if the levels are less than 5000, tubal mass is less than 3.5 centimeter, no fetal cardiac activity. There should be no cardiac activity. Contraindication include if patient have renal disease, if we have patient have liver failure, if the patient is already breastfeeding, laparoscopy is also effective in these patients. Laparoscopy हम करते हैं patient में if these things are not present like beta hCG level is greater than 5000, the mass size is greater than 2.5, or it has 3 fetal cardiac activity. All RH negative patients should be treated for ectopic and must receive RH immunoglobulin. So here's the so we can also consult like OBS and gynae so we have to remember. And the other is yeah, in the test the tests are the same, but we have to do the surgical tests in this patient, like type and cross match, blood group and RH, PTPTT, and LFTs because we have to give methotrexate and we have to rule out infection sites. Okay, so if the patient is stable, then we can do both methotrexate or laparoscopy, but depends on the level of beta hCG and the size of the lesion. Unstable. If the patient is unstable, what we have to do is first we have to do NPO, and after nil per order, we have to assess IVSS, administer nodal saline, type and cross transfuse as needed, continuous BP monitoring, PT-PT and we have already ordered BTIC pelvic ultras. The consult surgery and obs and gynae for possible to do laparotomy for this patient. Okay. अब अगर एक पेशेंट में मीरा vulvovaginismus के sign और symptoms के साथ आ रहा है, so what we are gonna do with this patient? If the patient is coming with candida vulvovaginitis, first we will do the physical examination, then we will order vaginal pierce, vent mount, vaginal gram stain, gram gonorrhea chlamydia culture, urine analysis. Then we will advance the clock to if the results are pH if it's normal and vent mount shows the candidiasis, then we can obtain the remaining result later. We can start. I thought we will give fluconazole, but in the our study session in the U world is measured, we have to give the miconazole vaginal continuously. We have to consult the patient. We will appoint the patient in 2 weeks, and the results of other tests we will be seeing, and we will have rule out other things. So that's the case. Then we will consult the patient about patient education, safe sex, no alcohol, if patient is taking alcohol, smoking, anything else. Patient come with. The other scenario, if a patient come with fibroadenoma, then we will do the physical examination because the patient depend on the age. If the patient is above uh, 30, then we have to order mammography, PRET, ultrasound, both we can order for the patient. Then we will schedule the appointment 1 week, and if we see what's the result is fibroadenoma, then we will interval follow up, patient reassurance, counseling the patient regarding patient education, a contraceptive advice, safe sex, smoking cessation, alcoholic patient. We have to give safety plan whenever a woman comes with partner, seat belt, regular exercise, pap smear if she needed it, schedule appointment in 4 months. We have to see the patient for fibroadenoma if it's increasing or those we can do like 3 months, 6 months for 1 year. We have to follow up the patient. So whenever what is the approach of a patient with solitary breast mass, begin with ultrasound and FNE. Ultrasound, if shows simple set, no further work. A complex is solid, then we have to do FNA. If an FNA show, if cytology is positive, then we have to do. If cytology is negative for cystic hair but non-bloody hair, reassure the patient and repeat examination 4 to 6 weeks to see if the left has returned. If reassurance, refer for surgical. If recurrence, refer for surgical intervention. If solid appears malignant or suspicion, then we have to do the excision or the definitive therapy. If solid and appear benign, then mammography for age women greater than 35, we have to do mammography. Solid or benign, then we have to do mammography only. A solid and appear malignant, then we have to treat the lesion. If mammogram negative has and repeat exam in 3 to 6 months, mammography does not detect 10 to 20% of breast masses. Therefore, negative mammography should not preclude triple diagnosis. If positive, then we have to do maybe the excision if it's malignant, or we have to do additional imaging like FNE. FNE, we have to see cytology of the patient. So this is how we approach the patient with fibroadenoma cyst in a. So if the patient, another gynec patient come, now she is having in the emergency department with pelvic inflammatory disease. She is in pain. So what we are gonna do is we will order the like infectious first because he's coming in the emergency department with pain. We will give her phenol because she's also vomiting and nauseatic. We have morphine, IV9, normal saline, IVSS, and then we will order the test CBC, PMP, beta HCG, urine analyzer, urine culture, cervical gram stain, cervical clinical culture, cervical chlamydia culture, pap smear, ESR, VDR, LGI, blood culture. Chat. Advance करेंगे. If the pregnancy is negative, then we will see gram stain. What is the gram? Supposedly it was positive or gram negative Diplococcus. Then we will transfer the patient to the ward. Then we will order doxycycline continuous IV and cefoxitin, acetaminophen for pain, normal saline. We will order because pelvic inflammatory disease and PO bed rest with bathroom pelvises. We will follow up the patient for 12 to 24 hours. We will request follow-up examination for abdominal genital until the patient improves. Then we will change the patient. Then after some time, we will change the like if he improve within 24 hours, then we will change to doxycycline oral counseling, and we will cancel IV fluid, IV cefactone, IV doxycycline. We will, if the patient is stable, we will send to home and schedule appointment in 7 days. So what is the treatment for pelvic inflammatory disease? The treatment for pelvic inflammatory disease, uh, we will, if the patient is come in inpatient, we can order IV cefoxitisine or IV cefotetin plus IV or paroral doxycycline, or we can give CG like IV clindamycin and gentamicin, or we can give IV ampicillin sulbactam plus IV or paroral doxycycline. We can give oral doxycycline. Initially, patient is able to tolerate paroral intake. Switch to entirely paroral antibiotic after 44 hours, sustained clinical improvement. This is the thing which we have to remember. So we can give CZ drugs like clindamycin, cefotaxime, or doxycycline and gentamicin. Outpatient we can give ceftriaxone IM 1 dose, yeah, plus doxycycline per oral for 14 days. If a patient is outpatient, or we can give cefotaxime IM 1 dose plus probenecid per oral 1 dose for 14 days. So which one will be preferred? I think the other one, which is 1 dose. Metronidazole may be added to either regime for suspected bacterial vaginosis, trichomoniasis, abscess, or recurrent gynecological inflammation. Follow up within 72 hours. So, if the patient is outpatient, we have to see the patient in 72 hours. Okay. Treat the patient, counsel the patient, contraception counseling, medication compliance, safe sex, counseling, and smoking cessation. When we have to take the patient inpatient, when we have to transfer the patient to ward if a patient is PID, she has fever of 102.2, severe abdominal pain, inability to take oral antibiotic, nausea, vomiting, leave for response to oral antibiotic, or non-compliant, pregnant. If she has abscess, then we have to take the patient inpatient and we have to give the treatment to the patient. Okay. In the outpatient, we have to give the treatment for 14 days. In the inpatient, we have to give IV, then after 24 hours, then we have to convert it to oral. So this is our cases for gynae knobs.